Okay, this is Scott Lindquist. I just want to clarify that I am the state for Washington State, the TB consultant. And what we're going to talk about with Chris Jeffris, who's the public health nurse in a county called Chelan-Douglas, is really how do you decide and implement a shift in the paradigm? Now, the current paradigm being where local health jurisdictions provide the care for latent TB infection. You saw in Dr. Jackson's study where more than 70% of the care was being provided in local health jurisdictions. The new paradigm being community providers taking on a greater role in LTBI treatment. And how do you, as a local health jurisdiction, make this decision, and how do you in the private community take on this role? So we're going to give you our example of how we did this in Chelan-Douglas County. And, you know, I think all of this is really due to timing. And in this health jurisdiction, the timing was right. This is a small, very progressive local health jurisdiction that had really embarked on a good internal look at itself and how it was doing tuberculosis. Now, in the state, we were doing what's called cohort review, where we're actually reviewing the care of cases, of active cases around the state. And to be honest, we had concerns in this county. So the county responded. They hired a new nurse who was Chris Jeffris, who's been there for, about 5 years now. And she really took the lead on this and looked at quality improvement in the entire TB program. So this is a great time to really discuss what are your priorities, should we be doing LTBI. So that was really what started the ball moving here. And plus, the administration in this health jurisdiction was a brand new administrator, and he was really looking at decreasing revenue. So for a lot of us, the decision to do LTBI in public health is made because there's no money. But in this jurisdiction, because of the quality improvement, because revenues were decreasing, that the program really got together and set some priorities for this local health jurisdiction. They actually looked at their data and said, well, who are we really treating? And so they did a 10-year case review to see who are their cases. And the majority of cases in this county, by the way, are migrant farm working communities. So it's mostly Hispanics. And fewer U.S. foreign folks have been in their care. And then the other part that was important here was that the public health jurisdiction really took on IGRA testing. And the local health jurisdiction was the champion in IGRAs, and the community was starting to look at this and say, well, we could do IGRAs too. So when the health jurisdiction sat down and really talked about prioritization, this is really the health officer, myself as a TB consultant, and Chris Jeffris as the public health nurse, and then the CD management or administration sat down. We said, our most important part here with limited dollar is to find active cases and treat them appropriately. And so a lot of the limited resources went into finding these active cases and concentrating on doing timely, complete contact investigations. And then doing community protocols, making sure that the shelters have protocols on how to look for TB, same with jail and migrant clinics, which provide the biggest stream of active cases in this county. And then this clear need for training and education. If we were going to pass off or at least hand over a lot of the responsibility for LTBI, how well was the community trained, and did we give them tools, which Chris will share with you in a minute, to really do this job well? And I'll be honest, we were maybe shifting from one paradigm to another makes you nervous, and you think the way you do it is the best. We had a hard time letting go of the way we were doing LTBI and feeling comfortable that the community was going to do it as well as we are. And, I think those are fair concerns that we have, but I think the community will handle this well. So one thing I want just a sense of everyone on the call is, are your programs, whether you're private or in public health, are you doing LTBI diagnosis and treatment now? So if you could score, look how fast you guys are. Good for you. And I'm going to show you the results here. And the results say that many of you are still doing LTBI. So really, this is a really timely decision if you're in local health right now. How do you make this decision to shift your paradigm? One thing I would just give you my advice on this, on having done this, we'll get into the nuts and bolts of this in a minute, but really my advice to you is you got to have some administrative support. I really think you as a local health jurisdiction needs to sit down with your administrator, your health officer, and I know it's hard to get the health officer to the table on this sometime, but the CD manager, and you sit down and you discuss your priorities for the program and talk about, is it even feasible to transition LTBI treatment to the community? And in some communities it will be, in some it'll be a bigger challenge. The other is to really make sure you have community support before you start down this road. And so we really explored the feasibility with the lab managers in this county, the medical directors of the community health clinic and the migrant health center and the hospital. We also looked at employee health and infection control folks. And the majority of these, although some were reticent, really gave us the green light to move ahead and explore this paradigm shift. Now, just to give you some perspective before Chris goes over the details, this is a map of Washington State. If you don't have this, please, I'm sorry, it was a late addition to the slide set, but on your screen you should see a map of Washington State, and our state is really divided almost in two halves. The west side is really the Seattle side, which tends to have the biggest population, and then the east side tends to be more farmland and rural, and this county kind of straddles both. It's two counties together that form one health jurisdiction called the Chelan-Douglas Health Jurisdiction. Now, I'm going to introduce Chris Jeffris, who I got to tell you is a public health nurse, and I talked to a lot of public health nurses who has a real passion for doing quality assurance, and she and I communicate a lot, and I think that has been a real key to success. So, Chris?
All right, thank you, Dr. Lindquist, and yeah, it's quite an undertaking. Before I get really going on my portion of the presentation, though, I want to broaden the snapshot of us a little bit just to give our audience a better sense of what we've been working with. Well, this is our building, although it's got a lot of snow on it right now. But our two-county area covers a geographic area of 5,000 square miles with a population of 112,000 people combined, and 28% of our people are in high-risk groups. We have averaged about 2 to 4 active cases per year, and I'm the only TB nurse we have, and 99% of my time these days is dedicated to our TB program. So, you could see from that map that we're big geographically, but a little shy on resources. But as Dr. Lindquist discussed, overhauling our program and really reshuffling our priorities was ultimately vital to us being able to accomplish this transition of latent TB care. And we didn't know it at the time, but it was during this 2-year overhaul that we were laying this foundational structure that was going to be really essential to us later on. Before we could make much progress toward our priority goals of case finding and treatment and contact investigation, as Scott said, we had to find some time, or actually more accurately, intentionally make time to do this work. And so how did we do that? By drastically reducing our volume of direct service. This included eliminating our immunization and STD clinics, for one, which I used to share work in. Going to targeted testing certainly helped. I think the thing that's had the biggest impact, though, was incorporating the quantiferon testing, and that reduced our false positives, which then dropped our LTBI caseload by a whopping 70%. And then, as Scott also said, when the community took up quantiferon testing, doing that in their own labs, we get a lot fewer referrals for people with positive skin tests. And I think there's something else that we did that's worth mentioning here, and that's we improved our office efficiencies, too, by eliminating walk-in appointments, reorganizing our patient flow, redesigning our exam rooms and paperwork and all of that. And each of these changes made time and improved our ability to get out of this clinic and into the community, into the shelters, the jail, the nursing homes, the clinics, and other facilities, and made time for us to engage with the private sector. That foundational structure I mentioned consisted not only of a program restructure, but also of strengthening and expanding our networks, relationships, and partnerships with the healthcare community. And Dr. Chen noted that importance of these partnerships. Getting to know people, learning about their organizations, educating about TB, and we'll talk a lot more about that part. And perhaps most importantly, building trust out there. And now there's dozens of ways to do this. I just got on the phone and started calling people and asking for informal meetings. And at that point, we were introducing quantiferon, and I was able to use their interest in this new test as a tool for getting my foot inside the door. Now we have the new 12-dose regimen that could be used as a tool for that. And, one example of a success that we've had is that, in talking about quantiferon with employee health nurses at one of our hospitals, it resulted in them recalling almost 40 employees who had positive skin tests. And what they learned was that most of those employees had never been counseled about LTBI or treatment. And after they received that counseling and education, many of them went on to be treated. And it's, by the way, these employee health nurses and infection control nurses, like Scott said, that can be your insider to champion TB in an organization that might not open its arms to public health so readily. And another way to build your network, your relationships, is to provide TB education. And my mantra is provide it to as many people in as many places as you can, because these kind of meetings are like a snowball. They, snowball rolling down the mountain gets bigger and bigger. So for one small example, I drove up to a little clinic up the valley. It was 45 minutes away to teach TB to 6 nurses there. And that class not only allowed me to meet them, but also their administrator for the first time, so that we could start establishing those important personal relationships. And then this first class led to Dr. Lindquist providing education for their 6 physicians. And those presentations that we do provide opportunities for those physicians and nurses to ask questions, to get to know who their local resources are, and for us to be able to give them our TB toolkit, which I'll mention in a minute. Now, you might be thinking that educating these small groups is squandering your precious resources, but I don't really agree with that. And I don't think Scott would either, because about 1 week after we provided these physicians with that class, we started getting the first of many calls from that clinic asking for guidance about their patients. And that's just the payoff that we're looking for. So then in early 2010, we put our toe in the water, I guess you could say, and started encouraging physicians to treat their own patients when they called us with a referral. But we were offering a choice. Either they could treat the patient with our support, of course, or we could go ahead and treat them. And as Dr. Jackson discussed, physicians may lack enthusiasm for taking on this group of patients for a variety of reasons. And what we found was that about 20% were willing to treat their own, but about 80% preferred that we go ahead and treat the patient. So a few months later, our team decided that we could no longer afford to treat LTBI at the LHJ level any longer, and we were ready to move forward. And like Scott said, it was a little bit of a hard decision because we had worked so hard on our LTBI program. But we talked to other health departments first to see, how they had transitioned it. We found a few that had. And what we found was that nobody was doing it the same way. And really none of their approaches seemed to be a very good fit for us. So we ultimately decided on our own approach, and that was that 100% of the new patients would be referred to a primary care provider. We would make no exceptions, at least for the time being. We did want, though, to finish treating the patients that were currently on treatment at the health department. And then we would provide plenty of education in advance of our go-live date. So then in January 2001, we had our first meeting with the medical directors in the community, and we really just asked them, what can we do for you to ease this transition? And there were 2 things that everyone wanted. One was education, and secondly, they asked that we send out a joint letter signed by all the public health leaders and all the medical directors, announcing our intentions and then our go-live date, which was April 6th of 2011. And then we talked with the pharmacy managers, suggested that they consider adding isoniazid and rifampin to their formularies if they hadn't already. And we did find some that weren't carrying both drugs, so they appreciated being called on that. And we also gave a heads up to the lab managers and cautioned them that they might see a rise in the demand for quantiferon testing. And then 2 months before our go-live date, we mailed that joint letter together with flyers about a series of upcoming education that we had planned. And our health officer attended many of those physicians' classes, not only to show support for this transition to the community, but also to hear the feedback from the physicians. And at each of the classes for the nurses and the physicians, we provided a TB toolkit, you could call it, which was a packet of resources, and you'll see it in just a moment. Then after our go-live date had come and gone and providers were encountering LTBI patients that they'd be treating themselves, we started getting more requests for more education, and we did go ahead and provide that. And this is a snapshot of some of the items that we put into our TB toolkit, and this is available to you. You should have received an email with a link to this toolkit item on the Curry Center's website. But our packet included our chart forms. We had created a pre-printed physician LTBI order sheet. We had a variety of treatment guidelines in there, some helpful algorithms, some guidelines for using eGRAs. We also had samples of patient education and a list of resources where they could get more information, like at the Curry Center website or the Department of Health at the state level and the CDC. And we also included my phone number, but as well we included Dr. Lindquist and the Curry Center Warm Line, where they could obtain expert medical consultations. I would say there's no question that all organizations are already working to improve the health of their patients, but there's a lot of variation in the type of care patients get. And we can all improve when it comes to care coordination and disease management. As for us, over the last 3 years, we've worked very hard to improve our LTBI treatment completion rate. 4 years ago, it was a dismal 27%, but in 2010, it was 87%. So the question became, how can we help the private sector duplicate our success? And so at various times during this transition process, we've proposed to our community partners the idea of developing an LTBI nursing case management model that would be similar to our own. And as Dr. Lindquist discussed, timing can be really important. And as luck would have it, our community clinic, where most of our patients are served, they informed us that they had made the decision to go ahead and move to a nursing case management model for other chronic diseases. And the exciting part was they were willing to use the LTBI patients as a launching pad. But one of the problems we face is that they've only just begun this project, and so their team roles hadn't been defined. There were no written protocols yet, and there had been no staff education. But even though we felt like we're putting the cart before the horse a little bit, our partner wanted to forge ahead anyway, and we collaborated with them and provided an introductory case management class for the nursing staff and offered to provide nursing mentorships in our TB clinic. So now we're at a point where we're planning more education, and we're also focusing on our FQHC more than the other clinics. We're going to be providing a weekly series of what I call mini classes for the clinic nurses on LTBI nursing case management, and these will be narrowly focused, like 15-minute trainings that will allow the nurses to leave their units without stressing the staffing levels. And we'll be teaching a single topic at each session. For example, we'll do one on lung auscultation skills because in fact, most of these nurses have not practiced that skill. Another one will be on performing an assessment for hepatotoxicity. We're also publishing a TB newsletter that's appropriate for any clinician, and we're ready to distribute our first nursing case management newsletter as well. That'll be an adjunct to these mini classes that we're doing. And in the meantime, the community clinic is working on their case management protocols, and we've offered to help with that if they need us. And what we've observed so far with getting this far with it is that the nurses are intimidated really by the idea of becoming case managers. It can be a bit overwhelming for those who've never done that before. And, it's raising the bar, which is never very easy. So I feel that my challenge is going to be working with my partners to provide this model of excellence, to educate people in ways to achieve really strong outcomes, and to provide helpful feedback. And it's important that I affirm that this challenge is worth the effort and just be a cheerleader for the effort. As far as quality assurance goes, we have developed a satisfaction survey that we'll be sending out soon to assess how the clinicians have perceived the education and support we've provided so far. And like our previous speaker said, we do have access to the electronic medical records, so we could do some kind of remote chart auditing. If we do that, we'll be focusing on monitoring only the high-risk patients. But in any case, it'll be important to provide constructive feedback to the senior leadership and all the management levels and to the front line as well, with the ultimate goal of improving treatment outcomes. So I think the lessons that we've really learned are that we're still learning because we're still in this process. We're not as far along as Dr. Jackson's program in Seattle or Dr. Reeves' program in Denver, but this project and this transition has been transformational. We know that administrative support is vital, as Scott said. You need that from the outset, and your community relationships. I really think that education is a key, and the need for it is ongoing. Dr. Purdy talked about how important it is, education is to getting buy-in from the physicians, and you'll be hearing more about education from the next speakers as well. But you do have to make time to do this work, and you got to just take it one step at a time if that's all you can manage, even if it starts with baby steps, because nothing happens overnight. And for us, this has been a 3-year process so far, and is still ongoing. We have learned that there is a wide variation in provider needs depending on their level of knowledge and confidence, their prior experience with TB, and their level of interest, too. And as Dr. Jackson mentioned, physicians at a FQHC seem to have a little higher interest. Providers also like having a local expert they can call for help, especially someone they're comfortable with. So I think it's very important that you meet them if you can. It's not always possible, but in a smaller area, a smaller health jurisdiction like this, we have more opportunity perhaps in a bigger city. But we also need to be knowledgeable and to respond to their needs in a timely way. And it's good to stay in touch with people as you go along through the process so that you can continually assess and meet their ongoing needs. And I have one last piece of advice in conclusion, and that is that it really doesn't hurt to have a little bit of fun along the way. And it might look like I'm goofing off right here, but I'm really actually working very hard on my relationship with Tim, who is a physician assistant at our FQHC clinic. But it's these kind of interactions that serve to strengthen communication, trust, and rapport, which are really essential ingredients to any and all of our TB control goals. So thank you very much. And now I'd like to turn this over to Dr. Randall Reeves and Carolyn Bargman from the Denver Metro TB Clinic in the beautiful state of Colorado.